All right, folks, we're going to spend some time talking about STEMI mimics that you've got to know. Now, on the one hand, we never want to miss a STEMI, but on the other hand, it's also important that we not overdiagnose STEMIs and overactivate the cath lab as well. So again, why is it important that we know all of this information about ACS? As I mentioned in other lectures, ACS is one of those diseases that's very high risk, but if you make the diagnosis properly, there's a very high payoff. You know, it's a little bit different than something like an massive intracranial bleed, where patient comes in and if you play your cards right, there's still kind of a bad outcome. Whereas with ACS, if you play your cards right, there can be a really great outcome, but if you miss something, there can be a terrible outcome for the patient, and of course, there can be a terrible outcome for you as well because of the litigious environment that many of us live in. I've mentioned in other lectures also that missed ACS accounts for 20% of all the money that our specialty pays out in malpractice, and a lot of these occur because of EKG misreads. Well, there's a significant cost associated with overreads also. I remember a study from out of Boston, I think, which said that when you activate the cath lab and the whole team comes in the middle of the night from home, that's about a $14,000 expense. And think about all that money that's being spent, and they come in and they cancel the case because they don't think it's actually STEMI. They think it was an overread. Well, not only does it cost a lot of money to bring them in, but oftentimes because of work-related hours and issues with fatigue, the team that woke up in the middle of the night and came in, they're not really allowed to work the next day and do procedures the next day either, depending on the hospital policy. So it's a big deal to call the team in. It's always better to overcall than undercall, but there's a number of things that we can do to minimize our overcall rate as well. This chart shows a lot of the different reasons why patients can have ST segment elevation. In the top left, that's the thing that we're worried about, acute myocardial injury. But there's a lot of other things that can produce ST segment elevation as well. We're not going to go through all of these, but we're going to talk about some of the key players and important things that are worth knowing about. So let's go through a few cases here. Let's start with this case. This is a 45-year-old man who comes into the emergency department with sharp chest pain. And the first question I'll throw out to you is, what do you think the diagnosis here is? He had some sharp chest pain. It was maybe a little bit pleuritic and maybe a little bit worse with moving around. And so the initial thought was, is this a STEMI or is this acute pericarditis? Well, take a moment and look at this 12 lead and ask yourself what you would do with this patient. Well, I think most people go with the diagnosis of pericarditis because there's a nice PR segment downsloping in a handful of leads, especially in those inferior leads. And going back, you can actually appreciate that there's ST elevation in multiple vessel territories, some in the limb leads, some in the precordial leads also. You've got PR depression. And so for all the world, this looks like acute STEMI. Well, pericarditis is actually not always that simple. The distinction can be very difficult, and this is definitely one of those conditions where you're kind of damned if you do and damned if you don't. If you have a case of pericarditis, which you call STEMI and treat the patient for STEMI with potent antiplatelet agents and heparin and even thrombolytics, you can potentially induce a hemorrhagic tamponade. And then on the other hand, if it's a STEMI and you call it pericarditis, that leads to delays in proper diagnosis. There's a study here by Larson which just highlights the difficulty in distinction. A lot of patients get diagnosed with STEMI and go to the cath lab, and after they squirt the dye, they find clean coronaries and then decide, well, it must have been pericarditis. So a lot of times pericarditis is diagnosed only after the negative cath. But again, when you mistakenly call it a STEMI, sometimes those patients can have adverse outcomes from the anticoagulants and antiplatelets you get. You never want to unnecessarily anticoagulate or knock out the platelets or thrombolyse pericarditis because you end up potentially with hemorrhagic tamponade. I've done it once, and I've seen a few other cases of the same. So whenever you're debating acute STEMI versus pericarditis, what I'm going to suggest that you do is go through a stepwise approach to how you make that diagnosis. And let's go through that. So when you're debating this diagnosis, the first thing I'm going to ask you to do is ignore V1 and AVR. Is there ST depression in any of the other 10 leads? All right. If there is, stop, you're done. It's got to be a STEMI. So pericarditis is not allowed to have ST depression in any of those other 10 leads. So if you see that ST depression, you're done. It's a piece of cake. That turned out to be a STEMI. If that doesn't get you to the diagnosis, then go to the next step. Compare the ST elevation in 3 and 2. If the ST elevation in 3 is greater than in 2, it's got to be a STEMI. You're done. If that doesn't get you to your happy spot, then go to the next spot. Go to the next step. Look at the morphology of the ST elevation. If the ST elevation is horizontal or tombstone, convex upwards, like something's underneath and bulging outwards on that ST segment, that suggests that you're looking at a STEMI. Pericarditis is only allowed to give you concave upwards elevation, but if it's convex upwards, it's got to be a STEMI. And then the fourth step, if you haven't arrived at a diagnosis of STEMI yet, your fourth step, if you see Q waves, but you know that they're new, that points towards a STEMI also. You know, I'll give you a little hedge there or caveat with the Q wave. So you need to be absolutely positive that those Q waves are new before you call it. I mean, you need to have an EKG from yesterday versus today and see clearly new Q waves, because if the EKG that you're comparing to is 10 years ago, you're not going to know whether the Q waves really are brand new or not. Okay, so after you've gone through all of these steps, if you still haven't arrived at a diagnosis of STEMI, then and only then are you allowed to look for PR segment depression. Notice at no point up until now have we focused on PR segments. And the reason why I really strongly advocate not looking for PR segments until you've gone through the other steps first is because we've all been taught a myth. We've all been taught that PR depression equals pericarditis. Wrong, wrong, wrong. Pericarditis is not the only condition that can drop your PR segments. STEMIs can drop your PR segments also. I never learned that in medical school or in residency or when studying for the boards, but it's absolutely true. Essentially, anything that messes with the atrium can cause PR depression. Atrial infarction, abnormal atrial repolarization, atrial ischemia, those can all cause PR segment depression as well. It's not just pericarditis. Nobody teaches that. So don't look for PR depression until after you've gone through the other steps first. It's interesting, when you look at the EKG literature, there's a few other interesting things about PR segments that I never learned in med school or in residency. Number one, PR depression is only reliably seen with viral pericarditis. It's not reliably seen with uremic or constrictive or other types of pericarditis. All right, that's important to be aware of. It's only viral. And then the other thing is that PR depression can sometimes be very transient. It might last only a few hours. So it's not always going to be there to help you out. But the most important thing I can say about PR segments is don't look for them until after you've gone through your other steps first. Now, if you go through all of these steps and you still don't have a diagnosis, then what can you do? Well, then I recommend getting serial EKGs. Because if somebody has an acute STEMI and they're ischemic, you probably are going to see things change on repeat EKGs, whereas if it's pericarditis, you probably aren't going to see things changing on repeat EKGs. So let's go back to the case that we started with, that the computer in this case called it acute pericarditis. The emergency physician called it pericarditis and admitted the patient to the hospital. The admitting physician called it pericarditis also, largely based on the strength of those PR segment depressions. But let's go through our stepwise approach. So step number one, ignore AVR and lead V1. Do you see any ST depression in any of your other 10 leads? The answer is no. All right, so let's go to the next step. Do you see ST elevation in lead 3, which is greater than in lead 2? Yeah, it might be. It might be a little bit. And that would say that this has to be a STEMI. But you know what? Let's say that's too close to call. So let's go to our next step. Next step, is there any horizontal or tombstone elevation? And your answer is absolutely yes. There's horizontal. So that also nails your diagnosis of STEMI. This turned out to be 100% LAD. The patient lost 8 hours of myocardium. And it wasn't until a second troponin was sent upstairs on the inpatient wards that the troponin was markedly positive. They realized it was a STEMI. and transferred the patient over to university, and this patient had 100% LAD. But everybody got fooled on this because everybody was first and foremost looking at PR segments. Do not look at PR segments. This is an example of your STEMI that can also produce PR segment depression. Horizontal elevation, it's got to be a STEMI. It's like federal law, okay? Pericarditis is only allowed to give you concave upwards. Concave upwards can actually be anything, but convex upwards or horizontal, that's got to be a STEMI. All right, let's go through some more cases, and we'll start out with easy and work harder. And I'll just pose these questions to you. Is this a STEMI or is this acute pericarditis? Well, this is clearly a STEMI because there's ignoring AVR and V1, there's ST depression. In AVL and V2, you're done. This has to be a STEMI. All right, simple enough. How about this one? Is this pericarditis or is this a STEMI? Well, if we go through our stepwise approach, ignore AVR and V1, is there any depression in any of your other 10 leads? The answer is no. All right, next step. Is there elevation in 3 greater than in 2? No, there's no elevation in either one. So go to your next step. Is there horizontal or tombstone elevation? Absolutely yes. There's horizontal elevation in V2, V3, V4, V5. This has to be a STEMI. Now, one of the reasons I like this case also, take a look in lead AVR. There is PR elevation in AVR. And there's some people out there that have been teaching for the past couple of decades that if there's PR elevation in AVR, that equals pericarditis. And that is absolutely incorrect. There's no literature to back that up. I don't know why people teach that. Again, as I said before, do not look at PR segments until you've gone through all your other steps first. This is absolutely a STEMI despite the PR elevation in AVR. All right? So this is a STEMI. All right, next one. How about this one? Well, this is also definitely a STEMI for a couple of reasons. First of all, you see nice reciprocal depression in lead 1 and AVL, and you also notice that there's elevation in 3, which is greater than in 2. Next case, this is a tougher one. Is this a STEMI or is this acute pericarditis? Well, you can go through your steps, and is there any ST depression in those 10 leads? The answer is no. Is there elevation in 3 greater than in 2? No, it's actually the other way around. It's greater in 2 than in 3. So we can't make any conclusions. Go to the next step. Is there any tombstone, convex upwards, or horizontal elevation? And the answer is no, all right? There's not. Everywhere it's a little bit concave upwards. So now we go to looking for PR segment depression. Is there any PR segment depression? And there is. So now you're allowed to look for PR segment depression, and you'll notice that there's nice PR segment depression in multiple precordial leads or downsloping. So this is a great example of acute pericarditis, all right? You've gone through your other steps, and now you're allowed to look for PR segment depression, and you find it. So call this acute pericarditis. Now, I'll tell you what happened in this case. The physician, in this case, called this an acute infralateral STEMI because the computer call this an infralateral STEMI. And the reason the computer and the physician call this an infralateral STEMI was because there's Q waves in the inferior and lateral leads. So they called it a STEMI. Well, there's no cath lab at this hospital, so they ended up giving the patient aspirin and heparin and thrombolytics. And about 45 minutes later, the patient was hypotensive diaphoretic. The voltage had decreased. This patient had developed hemorrhagic tamponade. And that's the problem with giving these type of medications to somebody with pericarditis. They can bleed in the pericardium. This patient had hemorrhagic tamponade, emergently had to go to surgery to drain off this hemorrhagic tamponade. Fortunately, the patient survived. And a few hours later, they got an old EKG and discovered that these Q waves were old. So I showed this case to you to point out again the caveat about Q waves. If you're going to look at Q waves, you better absolutely positively know that they're brand new. Because in this case, the Q waves were definitely old. They didn't know that, and the Q waves fooled them. So you might consider not even thinking about Q waves. Go through your other steps first, forget the Q waves, and then after those steps, then you look for PR segment depression. All right, how about this case? The EKG orientation is a little bit different. Your limb leads straight down, your precordial leads straight down also. This was my patient. I was taking care of, I was working an overnight shift, and this patient came in from the local prison. And unbelievably, he was having chest pain in prison, and they got an EKG on him in prison. And even more unbelievably, they sent it with him. So I had the benefit of looking at this EKG, which was obtained in the prison from maybe an hour or two earlier. And when you look at this, you can go through your stepwise approach, and there's nothing that rules in STEMI here. So then you look at PR segments, and there's beautiful PR depression in multiple precordial leads. So this is a great example of acute pericarditis. There's no reciprocal depression. ST elevation in 3 is not greater than in 2. There's no horizontal or convex upwards elevation. And so now you're allowed to look at the PR segments, and there's beautiful PR depression in multiple precordial leads. So I had a diagnosis of acute pericarditis. Great. Well, this is the prison EKG. He arrives in our emergency department. What are we going to do? We're going to get a new EKG. So take a look. Here's a new EKG. And now his PR depression is pretty much gone. So I show you this case just to point out how transient PR depression can be. Now, we had the original EKG, so we have our diagnosis here. But I like this case just to show, again, PR depression is transient. It's not typically taught that way, but it is. It can be very transient. All right, next case. This is a young woman who is in her 30s, no cardiac risk factors. Her pain's a little bit pleuritic, and her doc, it hurts a little bit more when I move a certain way. So she's young, no cardiac risk factors. It's maybe a little bit pleuritic and positional. Maybe it's pericarditis. The emergency physician looked at the EKG and wasn't really sure what to make of it. He consulted a cardiologist who happened to be in the emergency department seeing another patient. And I've presented this case so many times, I remember exactly what the cardiology consult said. The cardiologist came over, looked at the patient, and wrote his note. He said, based on the patient's age, gender, and absence of risk factors, and PR elevation in AVR, I agree with the diagnosis of acute pericarditis. ... But I'm still concerned, end quote. So that's what he said. So the cardiologist was thinking about pericarditis, but he said, you know what, I'm still a little concerned. So he said, why don't we get a troponin now and then repeat it in 2 hours? These are conventional troponins, not even the highly sensitive. So he said, let's get another one in 2 hours. So they got a troponin. It was pretty unremarkable, kind of top normal. The second troponin 2 hours later was clearly positive. So at that point, they transferred the patient over to university from this community hospital, whereupon this 35-year-old woman with no cardiac risk factors turned out to have 100% LAD blockage. Now, she did well. They only lost 2 hours, but you would not have even needed those extra 2 hours because you would have been able to diagnose this as a STEMI right from the start. Going through our stepwise approach, ignore AVR and V1. Is there any ST depression in any of your other 10 leads? And your answer is yes, absolutely. Leads 3 and AVF both have ST depression. You're done. This is a STEMI right from the start. You don't need to look at PR segments, and you certainly don't need to pay any attention to the PR segment in AVR. Here's another case. This, unfortunately, was a med-mal case. 38-year-old woman, no cardiac risk factors. I mentioned earlier that a lot of the malpractice cases I see are young women, all right? This patient, 38 years old, no cardiac risk factors. She comes in with this EKG. It's a little bit pleuritic, maybe a little bit, positional. And the EKG is read by the computer as pericarditis. The physician looks at this, thinks it's pericarditis. And the reason the physician thinks it's pericarditis is if you look at some of those leads, look at lead 2 and lead AVF and some of those lateral leads also, you see a little bit of PR downsloping. And on top of that, it's a young woman who's got no cardiac risk factors, very low risk profile for ACS. So the physician calls it acute pericarditis. Physician calls up to the intensive care physician and says, I'd like to admit this pericarditis patient to you. The intensive care physician haggles a little bit and says, well, you don't need to admit pericarditis to the ICU, but they go back and forth. Finally, the intensive care physician says, all right, fine, I'll admit the patient to the ICU. We'll keep a close eye on her, and then we'll send her to the floor tomorrow. It's a true story. 11 p.m., the ICU physician takes a patient, and the ICU physician happens to be married to a cardiologist. So she calls up her husband at home and says, honey, can you take a look at this 12-lead EKG on this patient? And she faxes him the EKG. You know, some of the younger folks out there may not know what a fax is, so let's pretend that she texted the EKG to him, all right? So the husband takes a look at the EKG, says, there's PR depression in a few cases, sounds like pericarditis, looks like pericarditis, call it pericarditis. All right, so the patient is admitted overnight in the ICU for pericarditis. First set of enzymes were unremarkable. Next set of enzymes at 6 a.m. the next morning are markedly positive. So they quickly transfer the patient to university, and this 38-year-old woman ends up having a left circumflex 100% blockage. And she ends up not doing so well. She ended up with a cardiomyopathy with New York Heart Class 3 heart failure, which means when she just walks her dog around the block, she gets heart failure. All right, so significant morbidity because of 8 hours of lost myocardium, right? We've all been taught time is muscle. When there's a delay to proper diagnosis, the patient's going to lose function. So a lawsuit was brought against the emergency physician and the intensive care physician for upper six figures, and there wasn't much way to defend it. If you look at this EKG, you would not have needed 8 hours to figure this out because this patient absolutely has a STEMI right from the very start. Let's go through our stepwise approach. Ignore AVR and V1. Do you see any other leads that have ST depression? And the answer is yes. AVL and V2, you're done. You don't need to look any further. But if you did, is there elevation in 3 greater than in 2? The answer is yes, you're done. It's got to be a STEMI. You don't need to look any further. But if you did, is there any horizontal or convex upwards elevation? And the answer is yes, leads 3 in AVF. So this patient has 3 reasons, all 3 reasons why this absolutely has to be a STEMI right from the very start. But because everyone just focused on PR segment depression, they ended up being misled. All right, take a look at this one. And I'll tell you, if you go through your stepwise approach with this, all the way through PR depression, you don't come up with an answer. So when you go through each step and you don't come up with an answer, what should you do? Well, get serial EKGs. And that's what we did. This is one of my cases. We got repeat EKGs, which did not evolve at all. This turned out to be just acute pericarditis, all right? Any other options? Well, if you're good with bedside echo, that's another option. You could do bedside echo and look for wall motion abnormality, which points towards STEMI, or pericardial effusion, which might point you more towards acute pericarditis, all right? I'll tell you up front, I'm not that good. I know basic bedside ultrasound, but I'm not good enough to rely on myself for picking up wall motion abnormality. Some of you are, or if you have an echo tech that can come down quickly, that works perfectly. And then the other option is send them to the cath lab. There's many, many cases of pericarditis that get diagnosed not until after the negative cath. So in those cases, obviously, even the cardiologist doing the cath wasn't sure. So I don't think you should ever have to apologize for getting cardiology involved in these cases as well, all right? What about serial troponins? You know, be careful about serial troponins because troponins can be elevated in STEMI or pericarditis, so they're not perfect. And also troponins take a little bit of time to increase, and so you might be losing time there with your STEMI. All right, how about this, STEMI or pericarditis? Well, this is definitely STEMI. There's reciprocal change in 3 and AVF, all right? And this is a case that we've gone over in the course a couple of times. This was diagnosed as pericarditis by the consultant cardiologist because of the patient's age. He was only 30 years old. So the cardiologist said it can't be a STEMI. It's got to be pericarditis. Wrong. If you look at lead AVL, there's depression there, and that means this absolutely has to be a STEMI. Here's a pre-hospital case where the paramedics called this acute pericarditis. But, you know, honestly, elderly women, are you ever going to call pericarditis in an elderly woman? That's got to take a lot of guts. But they called it acute pericarditis. And the reason they did is because if you look at 2 and 3 in AVF, there's some PR depression. And in AVR, there's also PR elevation. What did I tell you about PR segment depression and elevation of AVR. Don't look at that. You've got to look at the other steps first. And if you go through this, you'll notice that there is a little bit of ST depression and AVL, so you're done. This has to be a STEMI. And also, look at the morphology of the ST segments in leads 3 and AVF. They're downsloping. Pericarditis is only allowed to be concave upwards. So if you look at lead 2 could possibly be pericarditis, but 3 and AVF can't. It's got to be concave upwards for it to be pericarditis in all leads with ST elevation. So this was actually a STEMI also. All right? Okay, I'll let that sink in just a little bit. And we've gone through a stepwise approach. There's a couple of additional things that I might throw into the mix, which can be helpful also. But what you're seeing on this slide, I don't want you to use these at all until after you've gone through all of your other steps first. Then you use these, all right? So one of them is something that I call the check mark sign, or the RT sign. Essentially, when the R wave comes down and then bam, it shoots right out into the T wave. You can call it the BAM sign, all right? When the R wave comes down and then bam, shoots right out into the T wave, that's the STEMI. Pericarditis always gives you a nice gentle transition into the T wave. But if the R wave comes down and shoots right out into the T wave, or the S wave comes up and shoots right into the T wave, or it produces this check mark type of sign, that's a STEMI. And on the other hand, there's something called spodic sign, which is downsloping of the TP segment. I'll show you examples of this in a second. That's been shown to be suggestive of pericarditis. But again, these are not definitive, and so don't use these till after you've gone through your other steps first. Take a look. Here's an example of the RT sign, and you can look where the arrows are. Notice the R wave comes down, and then listen carefully. Bam! It shoots right into the T wave. That is a STEMI, right? Pericarditis just doesn't do that. In contrast, this is what normally pericarditis does. Take a look at how the R wave comes down and just gradually transition into the T wave. That's what pericarditis does, whereas the STEMI goes down and shoots right out in, oftentimes, not always, but oftentimes shoots right into the T wave. Here's a case where the computer was calling it acute pericarditis. Dr. Fertel here was smart enough to question that and said, well, could this be STEMI also? Well, if you look at a couple of these leads, you'll notice that RT sign. The R wave comes down in lead 2, right? Lead 2, see how the R wave comes down and then again, bam, it shoots right out into the T wave. That's the STEMI. Lead 1 is that gentle transition. Lead 1 could be pericarditis, but lead 2 means it can't be pericarditis. This has to be a STEMI. And then out in those lateral leads, you see that check mark sign. Once again, the RT sign or the check mark sign, that's very typical of STEMI. So this has to be a STEMI. This has to be a STEMI, all right? If you ever see this check mark sign, the R wave shoots right out, producing almost that Nike type of symbol, that check mark type of symbol. That's what STEMIs often do. Pericarditis should never do this. If you ever see this, you should really be hesitant to ever call it pericarditis. So that's the RT sign or the check mark or the BAM sign, whatever you want to call it. And then spodic, what is spodic sign? Spodic sign refers to downsloping of the TP segment. So from the end of the T wave to beginning of the next P wave, that's called the TP segment. And I think you can appreciate how it's downsloping. If you look at the overall EKG, you just get this sense in the precordial leads especially, how things are sloping down. When you see that downsloping, that's something called spodic sign, named after David Spodic, a cardiologist who did a lot of early great research on pericarditis. And that's suggestive of pericarditis, but it's not definitive. Okay, so don't use this until after you've gone through all your other steps first. Here's another very nice example of spodic sign. You see this downsloping of the TP segment. By the way, the computer, wrong as usual. Okay, here's another nice example of the spodic sign, downsloping of the TP segment. The reason I say don't rely on downsloping of the TP segment until after you've gone through all your other steps first. Take a look at this case. You'll notice here, this is the case that we definitely diagnosed as a STEMI. If you look carefully, we'll go through our stepwise approach here, all right? Ignore AVR and V1. Do you see any leads that have ST segment depression? Yes, AVL, you're done. This has to be a STEMI. Do you see any leads where there's convex upwards? Or tombstone? Yes, take a look at leads 2 and 3 and AVF. They're convex upwards, like something's underneath pushing up on those ST segments, causing the STs to bulge upwards. So this is absolutely a STEMI. And then this also has that RT sign in lead 2 and also in V4, V5. And in V6, you've got nice horizontal elevation. So there's a lot of things on this EKG that are saying this has to be an acute STEMI. It's a STEMI, all right? But if you take a look at the TP segment, you'll notice that some of the TPs are sloping downwards, all right? So that's why I say don't use Spodek sign until after you've gone through all your other steps first. And in this case, you'll arrive at a diagnosis of STEMI long before Spodek can fool you. All right, so go through your stepwise approach and save Spodek for the very end. And in many cases, you won't even need to get to Spodek because you'll roll in the STEMI. All right. Now, everything we've been talking about with STEMI versus pericarditis, we actually took all of this in a stepwise algorithm and we applied it to our own patients and we put together a publication on this, and it turned out to be really, really good. All right, I'm going to show you some odds ratios. Now, normally in research studies, when odds ratios are 2 or 3 or 4, those are really considered good. An odds ratio of 4, that's considered really, really predictive of something. Take a look at the odds ratios we found for what we just talked about. ST depression odds ratio 31. You could take this to the bank. This stepwise approach that we talked about, you can take it to the bank. ST elevation 3 greater than 2, odds ratio 21, and so on. The other interesting couple things we found in this study, 12% of patients, 12% of STEMIs had PR depression. So what do we say at the very beginning? Remember, PR depression is not equal to pericarditis. 12% of STEMIs in our study produce PR depression as well. And 5% of STEMIs produce that downsloping TP, that Spodek sign. So that's why I say don't look at PR segments till after you've gone through your other steps first. Don't look for downsloping TP or Spodek sign till after you've gone through everything else first. All right? You remember that case that we started with? There is PR depression and it fooled everybody. This was a STEMI. And I've seen a couple of other lawsuits where physicians missed the diagnosis of STEMI because they called it pericarditis because they relied on PR segments. Don't rely on PR segments till after you've gone through other steps first. All right? So, key points here. Pericarditis versus STEMI. The first thing you do is you look at things that are going to rule in STEMI. Is there ST depression? Is there elevation 3 greater than 2? Is there convex upwards or horizontal elevation? Call it a STEMI, be done, move on to the next patient. All right? If that doesn't get you your diagnosis, then also you can look at the checkmark sign, but look for PR depression, Spodek sign, checkmark sign after you've gone through the things that are listed on this slide first. These are the first things that you should look at. And then after that, then you're allowed to look for PR segment depression. All right? All right. Take a little mental break here about pericarditis versus STEMI. Very, very important stuff to know. Let's move on. We'll do a couple of more mimics. Take a look at this case. This 80-year-old brought in by ambulance for chest pain and shortness of breath. On exam, the patient looks relatively sick, tachycardia, tachypneic, blood pressure a little bit soft, pulse ox 95%, that's okay. And here's the 12-lead EKG, all right? So look at this EKG. The computer's calling it a STEMI. It looks for all the world like a STEMI. There's maybe an incomplete right bundle branch block, but there's ST elevation V1, V2, AVR, so it looks like a STEMI. Well, when you're reading an EKG, one of the things when I'm teaching EKGs that I really try to harp on is whenever you read an EKG, always go through your stepwise approach. Unless the patient's crashing and needs to be shocked right away or needs compressions right away, take 15 or 20 seconds and look at the rest of the EKG. Don't just focus on the eye-popping things that are hitting you, like the ST elevation is kind of an eye-popping finding. Everyone focuses on that. Look, take a step back, take 15 or 20 seconds, and go through a stepwise approach, rate, rhythm, axis, intervals, and look for other signs of ischemia. And if you go through your stepwise approach, rate, rhythm, axis, what's the axis here? Well, it's kind of a rightwardish axis. It's not necessarily a full right axis, but that's a really big S wave in lead 1. Normally, the lead 1 S wave is tiny or non-existent. Normally, lead 1 has just a big R wave. Every now and then, it'll be a big R with a little bit of an S. But in this case, the S wave is almost as big as the entire R wave. That should really stand out as being abnormal. And you should think about what your differential is for rightward or rightward-ish type of axis. Now, this is kind of the internal medicine differential. I don't expect you to memorize all of this. But what I do as an emergency physician expect you to do is to think about what are the things that produce a new rightward axis. Well, there's a few killers here. Pulmonary hypertension from PE can do it. Sodium channel blocking toxicity, hyperkalemia, and then misplaced leads. Let's assume the leads were double-checked and the leads were placed properly, right? Think about big PEs. Think about sodium channel blocker like tricyclic overdose. Think about hyperkalemia. But this patient also had ST segment elevation, so we're going to narrow the differential even more. Whenever you have what you think is a STEMI, whenever you have ST elevation and there's also a rightward axis, there's two things you've got to think about. Big PE and hyperkalemia. Now, I'm not talking about the little PEs that you all have while watching these videos. I'm talking about the big PEs that make people really sick. Big PE or hyperkalemia. Both of these can produce ST elevation mimicking a STEMI, typically with the rightward axis. No one ever teaches ST elevation. You know, for some of these, people learn about peak T waves, wide QRS, or S1Q3, T3, but these are notorious mimics of STEMI. So how do you tell the difference between these two things? Well, look at the rest of the EKG. Are there peak T waves? You could do a history if you want. Go old school, do a history, right? And then the other thing that you could do is grab your ultrasound and take a look at the right ventricle. And that's exactly what we did in this case. This was a big distended right ventricle. This was a massive pulmonary embolism mimicking a PE. There's quite a bit of literature talking about how PEs can mimic STEMIs with signs of right heart strain that look like cardiac ischemia, ST segment elevation, ST elevation, and AVR. And when patients develop these elevations, they are predictors of morbidity and mortality and hemodynamic instability. If your patient's not already unstable, these predict that your patient will become unstable if they're not treated really aggressively. And again, on this slide, I'm listing the different things that are signs of right heart strain, and I've highlighted the things that you need to pay special attention to for this section of this lecture. Whenever you have a patient who has ST elevation that looks like a STEMI, but there's rightward axis, think about PE. Because here's another important point. STEMIs don't tend to produce a rightward axis, all right? I'm not going to say anything in medicine is 0 or 100%, but it's very rare for STEMIs to give you a rightward axis. If you ever see what you think is a STEMI and there's a rightward axis, take a step away from STEMI and think about PE or hyperkalemia. And then how do you tell the difference between those two? History, look at the rest of the EKG for peak T waves, consider doing an ultrasound. And that's exactly what this was. This was a big PE. Let me show you some more examples. All of these are massive PEs or submassive. They're patients that are really looking sick. Take a look. ST elevation V1, V2, and AVR with a rightwardish axis. Big S wave in lead 1. ST elevation V1, V2, AVR with the rightward axis. ST elevation V1, V2, and AVR with a rightward axis. ST elevation V1, V2, AVR with the rightward axis. Notice your computer will typically call this a STEMI. Here's another one. ST elevation V1, not so much a V2, but AVR with the rightward axis. By the way, why those particular leads? Well, V1 sits on the right side of the chest. AVR looks at the right side. V2 kind of looks at the right side. So these are the leads that are looking at the right side of the heart. V1, V2. So whenever you have ST elevation involving the rightwardish leads, you should be thinking about PE and, of course, hyperkalemia. All right. Another one, ST elevation, V1, AVR, and a rightward axis, right? So please remember this. Whenever you have what looks like a STEMI, take a step back and look at the whole 12 lead. Go through your stepwise approach, rate, rhythm, axis. Don't forget axis. Axis is one of the most commonly ignored parts of your stepwise approach. Everyone learns to look at axis and then people forget to do it. Rightward axis is not that common. So when you see a rightward axis, well, think about some of the dangerous things in emergency medicine that can produce a rightward axis. There's not that many to remember. And if there's ST elevation also with the rightward axis, especially ST elevation in the rightwardish leads, V1, V2, and AVR, then you've really got to think about massive PE or hyperkalemia, all right? But STEMIs don't typically produce a rightward axis. All right, we'll let that sink in for just a little bit. And let's see, we got one more thing to talk about. This is a case that was sent to me by a physician in San Francisco. He was working a shift, and he had a patient who is 40-some years old who came in with nausea and vomiting for 12 hours. He had some upper abdominal pain, history of diabetes, and here's the EKG. The computer's calling it a STEMI. And so all of his colleagues are saying, you need to activate the cath labs. Colleagues are saying, activate the cath lab. The nurses are saying, activate the cath lab. The patients are saying, activate the cath lab. Everyone's saying, the janitors, everyone saying, activate the cath lab. But he said, you know what? There's ST elevation, V1, V2, and AVR with the rightward axis. So there's two things to consider, massive PE and also hyper-K, which is exactly what this turned out to be. You look, when you're debating those two things, what do we say? Look at the rest of the EKG, and now you can really appreciate there's nice T-wave peaking. All right, so what did he do? Instead of activating the cath lab, he just gave the patient a little calcium and bicarb, 1 amp of each, and immediately after giving those, here's the new EKG. ST elevation is gone. Now, your problem's not solved. Now that you've diagnosed hyperkalemia, you need to give insulin and more calcium and get nephrology to come and dialyze the patient and so on. But it's a very nice diagnostic challenge, just giving a little calcium and especially bicarb. People are not big on bicarb. I love giving bicarb when I'm in doubt. Just 1 amp of bicarb, maybe 2 amps of bicarb. Never hurt anyone, but it'll give you quick EKG changes. And then once you got your diagnosis, then you can go and give the proper full course treatment of hyperkalemia. So again, going back to what we talked about before, when you've got ST elevation mimicking a STEMI, especially in the rightwardish leads, and you got a rightward axis, these are the two things to think about. How do you tell the difference between a PE and hyper-K? Do a history, all right? And look at the rest of the 12 lead. Are there peak T waves elsewhere? And when there's still doubt, you can do a bedside echo. So let me show you some more cases. I'm going to start with fairly obvious hyper-K and work backwards. You'll notice in many of these cases, even with obvious hyperkalemia, the computer often calls these STEMIs because the computer wants you to miss. The people who program the computer interpretations, they I don't know who these people are, but they want you to be wrong. So take a look at this. I don't think anybody's going to get this wrong. But again, ST elevation, V1, V2, AVR, and a rightward axis. ST elevation, V1, V2, AVR, and a rightward axis. If you don't get a rightward axis, but the elevation is still on the right side leads, you still need to think about hyperkalemia and look for peak T waves everywhere, all right? In these cases, you've got a very nice rightward axis, and what do we say? STEMIs don't tend to produce a rightward axis. So ST elevation, V1, V2, AVR, rightward axis. ST elevation, V1, V2, AVR, rightward axis. The computer calls this a STEMI. Here's another one. Computer call this a STEMI also. It's not. ST elevation, V1, V2, AVR, and a rightward axis. Here's a patient who actually was diagnosed by the computer as a STEMI. So the physicians called it a STEMI, and they transferred this patient across Baltimore to our cath lab for cath. The patient arrived in the cath lab. The cardiologist took one look at the EKG, ST elevation, V1, V2, AVR, rightward axis. They canceled the cath, right? This was nothing more than a hyper-K. They gave some calcium, and they gave some insulin and some bicarb, and then just admitted the patient to medicine. No cath needed. ST elevation, V1, V2, AVR with the rightward axis. Here's one. Again, the computer thinks this is a STEMI. There's a nice ST elevation V1, V2 AVR with a rightward axis. ST elevation. I know you might be getting bored of me saying this, but I want to say it over and over so that every time you see this, the first thing that pops in your head is hyperkalemia, not STEMI. All right? The computer will typically call this a STEMI. Now, here's one that doesn't have a rightward axis, and the computer's calling it a STEMI. But you'll notice, again, there's ST elevation V1, V2, maybe a tiny bit in AVR. When you see this, now that you know hyperkalemia can mimic STEMI, get in the habit of looking at the whole 12 lead. And as I mentioned a few minutes ago, whenever you look at a 12 lead EKG and there's something jumping off the paper at you, resist the urge to make your diagnosis. Unless the patient needs defibrillation right now or compressions right now, take a step back and take 15 seconds and go through your stepwise approach. Rate, rhythm, axis, intervals. Look at all 12 leads. And even though this patient has a pretty unremarkable axis, when you look at all 12 leads, you can really see peak T waves, and you now know hyperkalemia can mimic STEMI. You realize this is not a STEMI. Hyperk doesn't produce, or rather STEMIs don't produce T waves like this. Here's another one. ST elevation V1, V2 AVR. There's no rightward axis in this case either, but you're going to look at the whole 12 lead and you see the peak T waves. This was Hyperk. Here's another one. ST elevation V1, V2 AVR. The physician was debating Brugada because Hyperk can give you a Brugada type of pattern in V1 and V2. But look at the whole 12 lead and you appreciate the peak T waves. This is just Hyperk. No cath needed. Here's another one. ST elevation V1, V2 AVR. When you see elevation that's localized to the right side leads, you should always be thinking about Hyperk and PE, despite what the computer is saying. All right. And here's one more case. Elevation V1, V2 AVR. This was taken care of by one of our senior residents. And the patient, again, the computer is misdiagnosing this as STEMI, but the physician, the resident saw this, and there's elevation primarily in the rightwardish lead. So she was thinking, could this be a PE or could this be Hyperk? Then she looked everywhere and saw kind of peakish T waves, and so said, well, let me see what happens when I give a little calcium and bicarb. So she gave 1 or 2 amps of calcium, 1 or 2 amps of bicarb, and rechecked the EKG about an hour later, and sure enough, you wouldn't need an hour. Bicarb works much faster than this, but as soon as you see the change, then you can now start with your calcium and your insulin and call nephrology. All right. So key points here. Beware hyperkalemia. It can do anything to the 12 lead, but one of the things that's often not taught is that it can mimic STEMI. Hyperk absolutely can mimic STEMI, and when it does, it usually will mimic STEMI by producing elevation in your rightwardish leads, V1, V2, AVR. And if you have a rightward axis, that's an additional gift that'll tell you that it's not a STEMI. All right, so let's go back and do some take-home points here. Please remember, large PEs and Hyperk are notorious for mimicking STEMIs, ST elevation V1, V2, and AVR, and often give you a rightward axis also. And remember that STEMIs just don't tend to produce a rightward axis. So whenever you see what you think is a STEMI and there's a rightward axis, please think about big PE and think about hyperkalemia. And with that, we will wrap things up. Again, there's my email. If there's any questions, please do not hesitate to shoot me an email. Thanks, everyone.